Dr. Panjat sort of gave a really eloquent overview of the physiology of iron metabolism and how there are two different kinds of iron deficiencies, absolute and functional iron deficiency. So, and you know that these are pathophysiologically linked to worsening heart failure. We know that these patients are at a higher risk if they have iron deficiency, regardless whether you have anemia or not. So now the question comes up that iron deficiency being treated with iron replacement seems like a really good idea. But one, what is the evidence that we should do it? And two, how we should do it. So let me just first start with oral iron. Giving oral iron to patients makes a ton of logical sense the way clinicians think, right? So it's easier on the patient. Yeah, adherence is a little bit of a problem, but trying to arrange for IV iron in the outpatient setting is a little bit tougher. It's easier in the inpatient setting. So why not just sort of give oral iron? That was actually tested, and the problem with oral iron is that as a clinician, I might find it easier to prescribe oral iron in the outpatient setting, and perhaps the patient does not need to make arrangements to come in and get IV iron. The problem is that it doesn't work, and it doesn't work both from a theoretical perspective, which we will discuss, but also we have now evidence-based as part of this NIH-funded trial called Iron Out HF trial. This randomized patient to oral iron replacement versus control. The iron deficiency definition here pretty much is standard. Ferritin less than 100 or between 100 and 300 with TSATs of less than 20. These patients underwent iron repletion. And the bottom line is that the iron repletion had no impact on patients' functional capacity. If you look at peak exercise oxygen consumption, basically it did not improve functional capacity at all. Now we have several studies that show that giving IV iron replacement significantly improves functional capacity, 6-minute walk test. So why did oral iron show absolutely no benefit as opposed to the IV iron studies that we have seen? And the reason goes back to what Dr. Panjat was discussing, and that is this issue of heart failure being a pro-inflammatory state. And in inflammation, one of the things that goes up is your hepcidin level. Hepcidin level then leads to dysfunctional ferroportin and basically iron transport issues. So you have a higher chance of developing functional iron deficiency. And that's why, although the oral iron is given, it is not absorbed at the gut level because of the relationship between hepcidin and ferroportin is what you need to absorb iron in the first place. Maybe there are some other additional issues as well in terms of GI side effects and patients not taking it. Maybe patients have not only lower extremity edema, but gut edema as well. That leads to absorption issue. But the bigger issue here is the issue of hepcidin levels. In this very trial, if you look at the quartiles of hepcidin level, one can start sort of understanding this physiology that the iron repletion parameters did work if your hepcidin levels were really low. But those patients with moderate to higher levels of elevation of hepcidin, there was no changes in the iron parameters overall. And that is the problem because of which perhaps we were not seeing the benefit, this pro-inflammatory state. So if you look at the iron out, as compared to placebo, those patients who received oral iron, there was a smidge change in the ferritin and the TSAT, really not enough to be able to show an improvement overall. So unfortunately, as it might be easier to give, oral iron therapy does not work.